Okay, I hope you can all hear me.
So we do the flyover to Europe now. At the lake of Zurich, in Zurich.
Thank you, Martin. I hope you can all hear me. I would like to share some thoughts about a side joint fusion, and since it's a biomechanical talk, I would really love to talk about some obstacles we come across, and some options that you need to have when choosing your implant. We all know that this is the road that a patient goes down. So usually it's a little bit hard in the beginning. There's going to be ups and downs, and then the patient will eventually end up much better than it was before, but maybe not totally pain-free. And in Switzerland, this looks like an optimal road. So from a surgeon perspective, that will be ideal. You have a large road, you have no obstacles, no traffic jam, and you'll end up right in paradise. But sometimes this is not the situation that we encounter in patients. Sometimes you will have roads that look like this. You will have roads that are dangerous, where the path is very narrow, where you have nerves and missing bone around your implant. And sometimes you just have situations where you have a traffic jam and there is simply no place for an implant. So these are the situations where we need to adjust maybe the size, the length, the path of the implants. And I would just like to go over some of these examples. Size and dysplasia, and we've just heard from Dr. Cross, dysplasia is a huge problem. If you have a patient like this who actually has a Bertolotti anomaly in addition, and you have a lot of space for the implants, this might be no problem using a standard implant in these cases. If, however, you are dealing with dysplasia of S1, with the mammillary bodies, with the missing bony formation of the sacrum in the proximal part, or if you have cases where really the SI joint becomes very, very small because you have almost a sacralization of the S1 and it leaves you with only 1.5 vertebra that you can cross with the implant, then you need to adjust the choice of implant. My background is pelvic trauma, clearly, and sometimes we have these cases that we fix a pelvic fracture, and then the only problem left that the patients have is SI joint pain. And there are cases where we're happy to help them using an implant, but then again, we would like to have more than just one implant just in case they become loose. Another common problem that we face in pelvic trauma is the implant migration both ways. That can be medially, but that can very often be laterally as well, where the screw just loosens and sticks out, and people present with this antenna, and then you're trying to get rid of the implant, but the washer stays. So clearly we needed a solution in pelvic trauma, and that was like a marriage. We needed to have a flexible construction, but still the washer and the screws attached to each other. So that was a solution in pelvic trauma. A postpartum example could be, that was a colleague of mine. She was anesthesiologist, and she gave me a call the next day after giving birth to her child, and she could not walk any longer. She asked me to fix her SI joint, but she was afraid of having the typical problem. So This is almost 15 years ago, we did not have the possibility of fixing the SI joint without crossing it. So we did an extra-articular placement of the screw in order not to have these problems. That can be another example of condensans or sacroiliitis, where you need to be very careful with the broaches. Weight bearing is definitely a problem, and this is especially true for the older patient population because they do not understand what it means to be toe touch weight bearing of 15 kilograms weight bearing, as we often have it. And I totally agree with the previous speaker, Dr. Cross, that compression is probably the way to go. The same applies, of course, for bilateral fusions, where we need to be able to fully bear weight from day one, because you cannot be toe touch weight bearing on both sides at the same time. Sometimes we have cases where we're afraid of bleeding. So the big broaches that we use with the standard implant might not be an option. So we want to have very small drills, very small implants, in order not to run into a problem. And then there's the big field of postoperative denervation. I do this routinely to almost all of my patients. And that means after the implant has fully grown in, we come back and we endoscopically denervate the painful nerve fibers wherever they are. We do test this preoperatively, and if this is a standard case with a standard pain after implantation, we then do a standard endoscopy and a standard denervation of the painful proximal joint. This might not be a problem. However, if you have cases that look like this, and for example, you need to address Bertolotti's anomaly, the proximal joint, the sacrotuberal band, and the lateral aspect of the sacrum that are all painful, this can end up in a full denervation where you clearly destabilize the joint. And in these situations, you want to make sure that your implant has fully grown in before you do such a surgery. And this is what it looks like. So we endoscopically look for the nerve fibers. The nerves are actually easily identified because they all have capillaries, so they're clearly seen. But sometimes you leave a big trough in the ligamentous part, and of course you want to have an implant that is completely grown in, and this is what it looks like. So we usually do a CT scan, or at least good X-rays, before we do a endoscopic denervation in order not to destabilize the joint. And again, what we've learned from trauma, I don't know whether any one of you has ever applied an external fixator to a tibia, for example. And if you look at the standard extraction torque of a standard pin versus an extraction torque of a coated pin with hydroxyapatite, this is insane, because trying to get this pin out, you would rather break a tibia before the pin would come out. And what we've learned from this is that we actually should use an implant that is coated with hydroxyapatite, and where we have the possibility of choosing a washer that fits the patient. And I would like to show a short video on the screws where we go into details.
So to understand the specific features of the Medacta Mass SI implant, you have to have a closer look at the mechanics of it. We have, on one hand, a fixed washer in combination with a part of the shaft that is not threaded. And the combination of these two leads to compression across the joint. So this is one key feature that we really can compress an SI joint, and that allows the patient to fully mobilize from day one, which means we do not need 6 weeks of partial weight bearing. The second feature is that it is coated with hydroxyapatite. And that means you have very good bony on-growth onto the implant. That means if at some point around the implant you have an osteolysis, which is very common with every implant you're using around the SI joint, that doesn't matter because you still have a very strong connection sidewards where you have compact bone. And the third thing is that we do have a revision screwdriver specially made for this that screws into the screw head and allows the implant to be easily removed in case you need to have another implant coming from the back, for example.
So coming back to the road that patients go down, but also surgeons go down, is this implant the answer to all our praise? Maybe not, but it can make this part very much shorter for patients, allowing them to fully weight bear directly after surgery. And the combination with the denervation, of course, allows us to achieve somewhat better results than the mean that is expected. And in this way, I hope that in the future, the combination of having an implant such as the Medacta one and with the denervation, this is bringing us a little bit closer to paradise. Thank you very much.
Thank you very much, Clément, for this nice talk and your explanation of your way, how you do it.